If you feel like menopause is changing everything, but no one's giving you any real options to feel better, this video is for you. In the last two videos, we talked about what perimenopause is and whether hormone therapy is safe, including why the WHI study scared so many people away from hormones. So now let's talk about the foundation of hormone treatment for many women, estrogen and progesterone. These are often the first hormones that we need to evaluate because they can affect hot flashes, night sweats, sleep, vaginal and urinary symptoms, mood, bone health, bleeding patterns, anxiety, and overall quality of life. In this video, we're going to talk about estrogen, progesterone, commercial versus compounded options, bioidentical versus synthetic hormones, labs, monitoring, and why treatment should be individualized. Because the goal is not to throw hormones at every symptom. The goal is to figure out what your body actually needs and how to treat you safely. I'm Dr. K, a pharmacist and a clinician who works directly with patients on weight loss, hormone health, and metabolic health. My goal is to explain these topics in a practical, evidence-informed way so you can better understand your body and make more confident health decisions. I've cited all my sources below, and remember, this is for education only. It's not personal medical advice. Now, let's break it down. Before we talk about specific hormones, I want to make one thing clear. We're not treating a lab number. We're treating a person. In a previous video, we talked about how labs can be tricky in perimenopause because hormones fluctuate. Treatment should be guided by symptoms and supported by labs, and not the other way around. Symptoms tell us what the patient's experiencing. Labs help us to understand the pattern, rule out other problems, and make sure we're treating safely. And if you're told, well, this is just menopause. Remember, menopause may be normal, but suffering through it is not something that you're required to accept. Common does not mean untreatable. I'm not going to give a blanket dosing instruction here because hormone therapy should not be copied from a YouTube video. The goal is to match the treatment to the patient, safely, thoughtfully, and individually. Let's start with estrogen. Estrogen affects tissues throughout the entire body, including the brain, bones, skin, blood vessels, vaginal tissue, urinary tract, joints, and the gut. Estrogen therapy can be very effective for hot flashes, night sweats, sleep disruption, vaginal dryness, urinary symptoms, painful intercourse, and overall quality of life. It can also help protect bone density as estrogen levels decline. There are three main estrogens we usually talk about: estrone, or E1, estradiol, or E2, and estriol, or E3. Estrone is the estrogen that tends to become more dominant after menopause. Some people call it the bad estrogen, but that's too simplistic. The concern is not that estrone exists. The concern is when estrone becomes disproportionately high because higher estrone levels have been associated with increased breast cancer risk in postmenopausal women. This is one reason I'm very cautious with oral estrogens. When estrogen is taken orally, it goes through the liver first, and more of it can be converted into estrone after being processed through the liver. Oral estrogen can also increase clotting-related proteins, which is one reason oral estrogen is generally associated with higher clotting risk than transdermal estrogen. So, for menopause hormone therapy, I generally prefer non-oral estrogen options. Estradiol, or E2, is the primary estrogen during the reproductive years. It's powerful, effective, and available in several commercial products, including patches, gels, sprays, vaginal products, and oral tablets. My preference is to use bioidentical and topical estradiol rather than synthetic estrogen-like compounds when hormone therapy is appropriate, because I want the molecule to match what the body naturally recognizes. So if you're prescribed estrogen therapy, it's reasonable to ask, is this estradiol? Or is this a different estrogen-like medication? Estriol is often thought of as a gentler estrogen, and it's used most often for vaginal and urinary symptoms related to menopause. Currently, there aren't any FDA-approved estriol products in the United States, so estriol is typically available only through compounding pharmacies. Estradiol has more established use for systemic symptoms like hot flashes and night sweats, But estriol can still be clinically useful for vaginal dryness, irritation, painful intercourse, urinary urgency, recurrent UTIs, and other genitourinary symptoms. It can help restore healthier vaginal tissue, support vaginal flora, reduce vaginal pH, and reduce recurrent urinary tract infections in postmenopausal women. Estriol also has some supportive data for bone health, although estradiol has the stronger evidence base for systemic bone protection. This is where Bi-est comes in. Bi-est, or two estrogens, is a compounded combination of estradiol and estriol. In my practice, I often prefer Bi-est for certain patients because it combines stronger systemic estrogen support from estradiol with gentler estrogen support from estriol, especially for vaginal and urinary tissues. That doesn't mean that Bi-est is automatically better for everyone, and it doesn't mean that estradiol alone is wrong. I have many patients on an estradiol-only regimen. But for many patients, especially when genitourinary symptoms are part of the picture, a thoughtful Bi-est approach may be a better fit. Now, let's talk about progesterone. Progesterone is often treated like it only matters if a woman has a uterus, and I understand why. If a woman has a uterus and uses systemic estrogen, progesterone is usually needed to protect the uterine lining. Without enough progesterone, estrogen can overstimulate that lining and increase the risk of abnormal bleeding, endometrial hyperplasia, and endometrial cancer. But progesterone is not only about uterine protection. Progesterone also affects the brain and nervous system. It can influence GABA activity, one of the body's calming systems, which is one reason some women notice better sleep, less anxiety, less nighttime restlessness, and less of that wired but tired feeling when they take progesterone. So when a woman says, "I had a hysterectomy, so I was told I don't need progesterone," my response is, maybe, or maybe not. If we're only talking about uterine protection, then no uterus means progesterone really isn't needed for that purpose. But if she's struggling with sleep, anxiety, mood changes, irritability, or feeling like her nervous system won't settle down, progesterone may still be worth considering. That doesn't mean that every woman needs it, and it doesn't mean that everyone tolerates it well. Some women can feel calmer and sleep better with progesterone. Others can feel groggy, flat, moody, bloated, or more tired the next day, or, in some rare instances, overstimulated. That's why the dose, timing, and the form matter. For many women, oral micronized progesterone at bedtime can be a good option because it may support sleep while also providing endometrial protection when needed. But if the dose is too high, or if someone metabolizes it in a way that makes them overly sedated or overly stimulated, we may need to adjust the dose, the timing, or the route, including considering compounded topical or vaginal progesterones when appropriate. This is also where I strongly prefer bioidentical progesterone over synthetic progestins when appropriate. Progesterone is not the same thing as a synthetic progestin like medroxyprogesterone, norethindrone, or levonorgestrel. These medications may still interact with progesterone receptors, but they can also create other testosterone-like or cortisol-like effects that bioidentical progesterones don't create. These can show up as acne, oily skin, mood changes, irritability, bloating, fluid retention, or just that feeling of being off. So if you've been told you did not tolerate progesterone, it's worth asking, was it actually progesterone or was it a synthetic progestin? Those aren't the same conversation. The goal is to ask, does the patient need uterine protection, nervous system support, sleep support, cycle regulation, or symptom balance? And if progesterone is appropriate, we use the right form, dose, timing, and monitoring for the patient in front of us. One more thing I want to emphasize, finding the right hormone plan can take time. Some symptoms may improve within a few days, others may take a few weeks, and some, especially things like libido, energy, hair changes, body composition, or vaginal and urinary tissue changes, can take several months. That doesn't mean treatment's failing. It means that we're individualizing it. Sometimes we need to increase slowly. Sometimes we need to back down. Sometimes one symptom improves before another one does. So don't expect perfection overnight. The goal is steady improvement, careful monitoring, and adjusting based on how the patient actually feels, not rushing the process or pushing hormones higher just because symptoms aren't gone immediately. Hormone therapy should be a guided process, not a guessing game. So here's the big takeaway. Estrogen and progesterone are often the foundation of menopause treatments, but they still need to be individualized. For some women, commercial estradiol makes sense. For others, compounded Bi-est may be a better fit. Some women need progesterone for uterine protection, while others may also benefit from it with sleep, anxiety, cycle regulation, or nervous system support. The right plan depends on symptoms, labs, risk factors, goals, and how the patient actually feels. And sometimes finding that plan takes time and a few thoughtful adjustments. So if you're struggling or just not feeling like yourself, don't accept "this is just menopause" as the end of the conversation. Menopause may be normal, but suffering without options is not something you're required to accept. Find someone who understands this area, listens to your symptoms, uses labs appropriately, and individualizes the plan. Because good care should not stop at "your labs are normal" or "this is just menopause." It should be thoughtful, guided, and focused on helping women feel like themselves again. Thanks for breaking it down with me today. I'm Dr. K. If you found this helpful, give the video a like, share it with a friend or family member who might benefit from it, and subscribe to the channel for more health topics broken down. And let me know down in the comments what topics you want me to break down next.